We are live, sir. Please start.
Good evening, everyone. I welcome you all for today's webinar on Oncology Reboot 2024. With immense pleasure, I would like to invite Dr. Jagdeep Singh, who is consultant medical oncologist in Cancer Center of America, Amritsar, for the welcome and introductory note. The stage is all yours, sir. Dr. Jagdeep.
Thank you, Vishal. So, thanks everyone for participation, and thank you for my colleagues who spared their time so that they can enlighten us on the new updates regarding the different scenarios of metastatic and non-metastatic settings in today's session of breast cancer. So, today we'll be discussing some of the new updates from the ASCO 2024. And we'll be starting with my first colleague, Dr. Sandeep Kukkad, who is a HOD and medical oncologist at Sohana Hospital, Chandigarh. So he's a well-known oncologist. He doesn't need any more introduction, I think. He's a good friend of mine, and he will enlighten us upon the recent update on this post-Monarch trial. So what are the further indications and what we are supposed to do a patient in the metastatic CA breast who have received this CDK4/6 inhibitor. So over to you, Dr. Sandeep.
Thank you, Dr. Jagdeep, for the invite and a nice introduction. And it's a good topic to discuss. I think let me share my slides first. So are the slides visible?
Your slides are visible. So you can put in the presentation mode.
There is some problem. My system. So the slides are not visible, or they are visible, still visible?
No, they are not visible, Sandeep, right now.
Just a moment, just a moment. There is some problem in my system. Let me.
Okay. No issues. You can take it.
Let me give me a moment. Now the slides are visible.
Yes. Now it's okay.
Moving?
Now they are moving. Yes,
They're moving.
Yes.
So thank you, Dr. Jagdeep, for the warm introduction, and we'll quickly go through what has been discussed in the recent meeting about the role of CDK4/6 inhibitors post continuation. That is what has been the standard, as we know, because there is a dilemma about what to do for the kind of patients that we have once they progress. So standard first line treatment for HR positive and HER2 negative patients, we all know that it is endocrine therapy with CDK4/6 inhibitors. And abemaciclib is a potent oral CDK4/6 inhibitor with a higher selectivity for CDK4 than CDK6, resulting in decreased myelosuppression, allowing a continuous dosing that we all know. FDA has approved this drug in combination with AI or with fulvestrant for HR positive, HER2 negative advanced breast cancer as a monotherapy after PD progression with prior endocrine therapy or chemotherapy in the metastatic setting, and for high-risk patients in the early breast cancer along with the continuation of endocrine therapy. Randomized phase 2 trials have been evaluating CDK4/6 inhibitors with their continuation after disease progression with CDK4/6 inhibitor and an endocrine partner, and they have reported an inconsistent benefits. So the current study, it demonstrates the efficacy and the safety from phase 3 post-Monarch trial, which evaluated abemaciclib with fulvestrant versus a fulvestrant monotherapy after progressive disease with CDK4/6 inhibitor plus endocrine therapy in patient with HR positive and HER2 negative advanced breast cancer. So that has been the dilemma about once your patient progresses on ETK and CDK4/6 inhibitors, what to do? Is it the way to give is only fulvestrant, or should it be a fulvestrant plus minus depending on whatever you get? If there are no actionable mutations like PIK3CA, BRCA, then probably you can change the endocrine partner as well as change the CDK4/6 inhibitors for a consistent benefit. That was the agenda of conducting this trial. So this was a double-blinded, placebo-controlled, randomized phase 3 trial where HR positive, HER2 negative, advanced and metastatic breast cancer patients who had received first-line CDK4/6 and an AI for advanced disease and recurrence on and after CDK4/6 in the adjuvant setting also with a good performance scale. They were randomized between two arms, abema and fulvestrant versus a fulvestrant approach. And the primary endpoint was a progression-free survival by the investigator. So the two arms were very well balanced. Majority of the patients, if you look at, the majority of the patients had visceral metastasis, 62%, and liver was the most common side, that is around 37% of the patients. The trial also evaluated the presence of an ESR1 and a PIK3CA alteration, that is 40%, around 40 to 50%, and a 50% of the patients had a PIK3CA and AKT and PTEN mutation, because we had the recent presentation in this ASCO as well about the role of targeting the PIK3CA, AKT and PTEN pathway with capivasertib. So this is about the treatment history. Majority of the patients, that is around 60% of the patients, had received palbociclib as a first-line treatment. Around 35% of the patients had received ribociclib as the CDK4/6 partner, and 8% of the patients had received abemaciclib. So you can see that majority of the trials, they were started earlier because the agent that was first developed was palbociclib. So again, for the post-monarch analysis also, majority of the patients had progressed on palbociclib arm. So if you look at the investigator-assessed PFS and a blinded independent review committee-assessed PFS, there is a difference, but the studies have consistently demonstrated an improvement in the progression-free survival, that is 6 versus 5 and 12.9 versus 5.6. So there is, you can see the Kaplan-Meier curves are very well separating, but the PFS in blinded independent review committee was affected by certain informative censoring, 51% with abema and fulvestrant versus 38% with fulvestrant monotherapy. And the benefit was also consistent with respect to age, region, metastasis, and the duration of CDK4/6. So this is about when you assess for whether the PFS benefit is consistent with respect to the presence of visceral metastasis or not, whether it is effective in terms of whether ESR mutation present or not, PIK3CA mutation present or not. So you have seen that if there is a significant exposure to CDK4/6 for more than 12 months, you can see that the difference has been high. As well as if there are visceral metastasis, again, the benefit for the addition of abemaciclib is again there. And for ESR1 and PIK3CA, the trial demonstrated a not reached result at the time of analysis. So it improved the overall response rate as well by investigator review as well as by BICR committee as well. So again, we know about the side effects, that whether it is diarrhea, neutropenia, as it is consistent with the other monarch trials, diarrhea is the most common. That is, you can see almost around 4% of the patients had more than grade 3 diarrhea, and neutropenia was seen, that is asymptomatic neutropenia is again seen in around 1 out of 4 patients. So the side effects are very well manageable. Only thing is you need to decide whether you want to continue the CDK4/6 post progression on the first line therapy. So this was one of the first analysis, that is post-monarch trial abema with fulvestrant after progressive disease, which demonstrated an improvement in PFS versus a fulvestrant monotherapy. 27% reduction in the PFS event risk with abemaciclib and fulvestrant, that with a hazard ratio of 0.73. The consistent PFS benefit was also noted in patient with pre-specified subgroups like ESR1 mutation and PIK3, AKT, PTEN alterations. So this is debatable, I would say, because for ESR1 and targeting the PIK3CA, you don't have a vis-a-vis comparison of adding fulvestrant with capi versus Sept. So again, this could be a point of debate in the coming trials also, whether to change the CDK partner or whether to change it to some targeting some other pathway. So the key secondary endpoints were also demonstrated the consistent improvement in the overall response rates as well. So it has a good safety profile, which is very well manageable. And investigators finally concluded that Abema with fulvestrant offers a targeted treatment option for patients who had progression on first-line ET and CDK4/6. But mind you, majority of the patients had received palbociclib in the trial and then switched over to abemaciclib in the second line. So thank you.
So thank you, Dr. Sandeep. So it was again a good thing to listen that post CDK4/6 and endocrine therapy, patient had some progression. We can challenge this next again, another second CDK4/6. The only thing is that majority of the patient were either palbo or ribo in this trial. So we don't have the exact trial. So it was just from the ASCO updates. So do you think that abemaciclib binds more binding is more as compared to the palbociclib? That's why we can use, or it has a more action as compared to the palbociclib. That's why we are used as compared to the abemaciclib, because the proportion of the patient they have already exposed to palbociclib is high. So does this make because when we have a head-to-head comparison of the affinity of this
So
drugs,
I would say that the drug is totally different, because we have seen the quantum of benefit. If you look at the absolute data, the quantum of benefit in terms of PFS for all the metastatic trial, whether it is Paloma, whether it is the Monarch, or whether it is the Mona Lisa trial, the PFS in the metastatic setting is almost the same. But still the drug behaved differently, because if you look at the adjuvant data, the trials for adjuvant palbociclib, 2 trials have consistently failed. And again, for Natalie and the Monarch trial, in the adjuvant setting, they also behave, the data says that the drugs are different. So looking at the metastatic profile, you believe that the mechanism is the same, but
So
mechanistically, if you say in a
maybe,
real world
yes.
practice, the drugs are different. So I believe that there is some sort of enhanced binding to CDK4 as compared to CDK6, and that we have seen in our day-to-day practice also. So
That's why this drug has some off-target side effects because of the change in the affinity. And of course, we have seen even that the patient who, there are some initial previous studies that patient who receive abemaciclib or the patient who have some brain metastasis, although they could be one of the patient who can be given this abemaciclib.
So for brain metastasis, I'm not sure whether,
because there is a data of complement trial for ribociclib,
okay,
but it was seen in the initial studies that abemaciclib has a better penetration or better permeation to the brain as compared to the other 2 CDK4/6 inhibitors.
So I think the whole crux behind conducting this trial was to assess that what should be done in the second line. Is it the continuation of CDK4/6, or is it changing the CDK4/6 backbone?
That could be one option. Other thing, like there was some initial studies of the ribociclib also as a continuation of CDK4/6 post progression of the previous like palbociclib and changing of the other endocrine partner in those patients. So this is a phase 3 trial with a good evidence that of course a PFS of close to 8 to 10 months or 12 months is a good to say, and definitely it will be a changing practice. And in those patients who are ESR mutation, that is one of the challenges with us, because we are left with the elacestrant, which is a very costly drug for those patients. That could be one thing.
Yes. So I think this would further evolve in future, because as I already said in my trial, in my talk, that now you have treatment options, whether it is PIK3CA mutated, whether it is AKT1 inhibition, or whether it is targeting the mTOR pathway, whether it is targeting the BRCA pathway. So you have few other options in the second line, whether it is alpelisib, whether it is everolimus, whether it is giving the germline BRCA inhibitors. So this would further evolve in future, that what should be the optimal second line of treatment.
So Sandeep, how you feel that this PIK3CA inhibitor, because personally my experience with the alpelisib and fulvestrant is not very good, means they don't yield a good result. I have seen, maybe I'm wrong, but whatever the literature say, I think I have not even touched the half of that PFS also.
No, no, I agree because alpelisib is a difficult drug to handle also. I don't think so that 300 milligram is an optimal dose to give in majority of the patients. I have tried in 2 or 3 patients, but I think again you have to come, you face a lot of challenges with hyperglycemia. But with the times ahead, now the recent data with capivasertib, I think the trial included even those patients who had a HbA1c level of 8. So in the future, maybe the second line treatment would evolve. That is, AKT inhibition would be a better alternative to rather inhibiting the PIK3CA backbone.
Okay.
So I had one of the patient who was started in 2019 on, say, alternate palbo and ribo because of the availability from ECHS. And she progressed in last November of 23. So we continued on Abima and fulvestrant. So why I just remember this patient because of the similar trial as we have discussed. She was PIK3CA negative, and
Okay.
she continues to be in complete remission. She had liver metastasis and bone metastasis. So she is at present in remission. So I believe that changing the CDK4/6 backbone should also work.
So thanks for your sharing this experience of this changing of CDK4/6 backbone. And right now, what you started has will become a standard of care in future with this robust data phase 3 trial. Thank you so much, Dr. Sandeep. Thank you so much.
Thank you.
So thank you. This was a good insight to the CDK4/6 post-projection first line and then the MSc. So my next speaker is Dr. Navdeep Singh. He is a medical oncologist at EOI Jalandhar. So he'll be taking on the patient with the triple negative breast cancer and the role of Evolumab in this. So a brave study. So over to you, Dr. Navdeep.
Good evening, sir.
Good evening.
I'll share my screen.
Technical support to share the screen for Dr. Navdeep.
No, I think it's is it visible, sir?
It is.
My
It
screen.
is.
Okay.
So can you make in technical support? Can you make in presentation mode?
Okay.
Yes, that's good. That's good.
From my side only, sir. Is it visible now?
Yes, it is. It is. It is
Okay.
okay.
Very good evening. Today I'll be discussing this trial, A-BRAVE trial, which is basically a phase 3 trial of adjuvant Evolumab versus observation in patients with early TNBC with residual disease, post-neoadjuvant chemotherapy, or at a high risk after surgery and adjuvant chemotherapy. So we all know that TNBCs are quite aggressive, and if the pathological complete response is not achieved, and we often face worse outcomes with this group of patients. So we often give neoadjuvant chemotherapy, commonly used in more than T2 or node positive tumors. Yes, in CT1C can be also used. And we know these TNBCs are quite immunogenic tumors. So immune biomarkers have shown some benefit in this subgroup of patients. And they can be used to predict IC immune checkpoint inhibitor efficacy. So this anti-PD-L1 antibody, we know Evolumab is approved by FDA to treat certain solid tumors like urinary bladder. So this trial was conducted as these tumors are immunogenic. So TNBCs are quite aggressive tumor if the pathologically complete response is not achieved. So in this subgroup of patients with residual disease after neoadjuvant chemotherapy, or if they are at higher risk of surgery after adjuvant chemotherapy, this drug Evolumab was tested. So currently, right now, what we are doing, we all know in TNBC, if pathological complete response is not achieved, we follow create X trial and we use adjuvant capecitabine. Yes, it again helped in DFS as well as OS benefit. And if the patient, we do test for BRCA1/2, and yes, if the BRCA1/2 is positive, we do like to consider PARP inhibitor. And we know we are using this in pembrolizumab immunotherapy in neoadjuvant and adjuvant setting on the basis of Keynote 522. which has shown around 37% reduction in the risk of death. But the problem with this trial, I feel, one is this initially the Pembro is given with the 4 cycle of AC and then with the 4 cycle of paclitaxel, which again it's a very toxic regime, and most of the times difficult to give this regime. And even if we can test even the patients after even initially 4 cycle of paclitaxel with immunotherapy, that whether PCR is achieved or not. Second, what after if the PCR is not achieved after neoadjuvant pembrolizumab, what should we do? Should we add capecitabine to the pembrolizumab, or if the patient turned out to be BRCA1/2 positive, should we do a combination with the PARP inhibitor? And still, these questions are still unanswered, but we might get an answer for these soon. And recently, there was another phase 2 data from ESCO also, in which they combined RT in the patients in which even the PCR was not achieved with the capecitabine, providing some meaningful results. So there is always space for improvement. So there is a need for definite need for something. So this trial again was a phase 3 trial. So in this trial, the adults with high risk TNBC, previous local, regional, and systemic therapy was given with curative intent. So they were divided into two subgroups. One was they were stratified by the adjuvant therapy, whether PN23, any T, PT2N1, or PT3T4. These comprise around 18% of the population, and then the other were the main were the 82% patients were the post neoadjuvant patients, these patients have residual invasive disease in breast or eggs in the lymph nodes. So the patients were randomized to this PD-L1 anti-PD-L1 avelumab 10 milligram per kg every 2 weekly for a year, and versus the observation. So the co-primary endpoint was the disease-free survival, and the disease-free survival in the post-neoadjuvant population, which almost were around 82%. And the key secondary endpoint was overall survival and the DFS in the PDL1 positive population, and the safety. So coming on to the baseline characteristics, the baseline characteristics were almost same. So again, the majority of the population was triple negative breast cancer and the proven FISH negative, which were the I1 plus or 2 plus on the ISC. And the again, you can see the staging. These most of the patients had a residual disease, either T1 or a node positive, and again were divided into adjuvant subgroup or a neoadjuvant subgroup. And then this is the RCB. RCB is basically it's a calculator. It's a residual cancer burden calculator, which divides these patients into the 4 categories. And in this calculator, these patients were divided in these 4 categories. And these are the number of patients which received adjuvant capecitabine. So coming on to the disease-free survival, this is the post neoadjuvant, which was a co-primary endpoint. You can see the 3-year DFS was 66.9 in the avelumab group versus 60.7 in the control group, with a delta of 6.2%. Only the hazard ratio was only 0.80, so which was not a significant. So the co-primary endpoint was not achieved in the this post neoadjuvant subgroup. But if you see the overall survival, which was a secondary endpoint, the 3-year overall survival was 84.8% in the avelumab group versus 76.3 in the control group, with a delta of 8.5. There was almost 44% reduction of death in this overall survival analysis, and the p-value was 0.035. So again, we have seen that DFS was not statistically significant. The hazard ratio were about 0.181, and for the OS again, the hazard ratio was good, and there was a meaningful benefit in the OS. After this difference, they did a post hoc analysis to see distance disease free survival. This is metastatic disease free survival. And again, the difference was 7.5 5 and the hazard ratio was 0.70. So that means definitely this drug was working in and helping in decrease in the mets. So and in the post new adjuvant, I have already discussed the EFS was not significant. The hazard ratio was 0.80. So coming on to about the safety, as this drug was given for 1 year. So most of the patient tolerated this drug well. The main reason for the discontinuation of the drug was disease reoccurrence, and a certain patient had immune side effects, which were mostly immune-related side effects. And you can see the immune-related side effects like hypothyroidism, hyperthyroidism, colitis. As we all know, these can occur with the immunotherapy. So these patients had the major side effects as immune-related side effects. So, according to investigation conclusion, this subgroup of patients, whether they have a disease after post-neoadjuvant therapy or after adjuvant therapy, so avelumab it provided non-significant improvement in 3-year DFS, but it significantly improved 3-year OS and distant metastatic free survival in intentional treat population versus observation. So the hazard ratio was overall survival was hazard ratio was 0.66. So again the patients in on the avelumab group, 72% of the patient they completed the treatment, and the patient which couldn't complete the treatment, the main reason for them was the disease reoccurrence. So so investigators they concluded that the avelumab as could be have a role in treating these early TNBC because these subgroup patients are immunogenic. So early TNBC and residual disease after new adjuvant chemotherapy or having some high risk feature after surgery and adjuvant chemotherapy. Thank you.
Thank you, Navdeep. So this is again another study in case of TNBC, which is again an unmet need in the patients. The thing is that we don't have the exact details what chemotherapies they have used.
Yes.
Because with the Paclitaxel, still we achieve a close to 40 to 45% of the patient with the PCR. So whether if we have a head-to-head trial with a sort of drug like capecitabine, whether it's going to give some benefit or not, because finance will be big issue with the avelumab. So still DFS is still not a significant. OS survival benefit was still, and we don't know by critical analysis we might be able to justify that whether this overall surveillance will be able to will be a marker to give this drug or not. This is one thing. Other, how to incorporate this drug with the PARP inhibitors, as you already mentioned in your previous slides. These are some of the questions which was just coming to mind while listening to you.
And secondly, sir, again, on most of our patients, if we are feeling that these are locally advanced high risk, we are incorporating new adjuvant pembrolizumab along with adjuvant. So again, where this drug will find space in that subgroup of patient, that is difficult to comment.
So other in last line, they have written that it could be one of the treatment option in the high risk patient after surgery and adjuvant chemotherapy. So that incorporation of that drug post adjuvant chemotherapy means what will be the outcome in those patients who have already not received PCR or who have received PCR, we are not sure. So the things I think in this trial, whatever the literature we have right now, though it is just from the ASCO updates, that when we have the result trial, we will be more able to answer. So it makes us little bit suspicious that whether using this drug, if the patient has already achieved PCR, will yield anything or not in the adjuvant setting or not. So if the patient have achieved non-PCR, then it's true that it is of course going to give you some benefit. But in PCR, we are not sure.
Again, sir, we will test the patients for BRCA1 and BRCA2 again. Whether to use it.
So with more coming data, I think it will be more of confusion only that which drug to be incorporated. And when you have even the PARP inhibitors, you have the pembro with you. So are you going to combine this PARP inhibitor with the immunotherapy at some point of time to get a better result? So the head-on head trial that could give a better answer in these questions, because a lot of data is there. What I just discussed with Sandeep, that we have a lot of data, but sometimes we are not able to get what exactly we have to give to the patient in a particular subset. Thank you so much. Thank you, Navdeep. Thank you so much.
Thank you, sir. Thank you, sir.
So this was regarding role of immunotherapy in TNBC patient. So that's Avlumab. So the DFS was not significant in this patient, but some overall survival benefit was seen. This. So next, my speaker is my colleague, Dr. Gurvinder Singh. I have seen him. He in between he switches on his camera, but right now it's switched off. Gurvinder, are you there?
Hello. Hi. Hi, sir. I'm here.
So I think you are still wearing the apron, or it is just reflecting to me.
No, I'm not wearing it.
So your next session is by Dr. Gurvinder Singh, who is medical oncologist at AOI DMC Ludhiana. He has recently switched to DMC just some couple of days back, and nice to see you. And you will be discussing on the dilemma and myths regarding the CDK4/6 inhibitor, which you use, why to use. So over to you, Dr. Gurvinder.
Thank you, sir. So, can someone share the slides from your end?
So technical support, can you share the slides?
Sharing, sir. 1 second.
So, dilemma of choosing a CDK4/6 inhibitor in first line. Is it a truth or real, myth or reality? Next slide, please. Next. So, what are the treatment goals in metastatic breast cancer? Next slide. So, main goal in physician point of view is prolongation of life and preservation of quality of life and improving the quality of life. That are the main goals in physician's mind. Next slide, please. So, what are the priorities from patient point of view? And so, most of the patients, they were ready to take the side effects if the prolongation of life is there. So that was the main goal from patient point of view. Next slide, please. So perspectives on clinical endpoint, whether PFS or OS. Next slide, please. So in advanced setting, we always say that overall survival is the gold standard. If a drug is improving it, then we consider it as a gold standard in the treatment. Next slide, please. So can a PFS advantage can predict OS? That is not always true. That we have also seen in many trials also. Next slide, please. So overview of the data that various trials are there with CDK4/6 in first line metastatic breast cancer or second line. And OS significant survival is basically with the ribociclib. Palbociclib has not shown. Rima has shown with fulvestrant, but not with the first line with letrozole. Next slide, please. So Paloma trial, changes in PFS has not implicated into overall survival. So OS was not significant, PFS was definitely significant in palbociclib. Next slide, please. Monarch 3 that has shown PFS advantage, but not a significant advantage in overall survival in the ribociclib. Next slide. There can be a lot of reasons, different population in the trials, different post-progression therapies, or difference in the intervention of CDK4/6. Whether they are acting on different CDK4 or CDK6. So there can be an explanation for these differences. Next slide. If we look into all these trials, baseline characteristics of patients are almost matched in all these trials. Next slide. So, as we know that we cannot compare the trials head to head, but still a matched adjusted indirect comparison was done of Rebo versus palbociclib in first line. Next slide, please. So if you look into match adjusted indirect comparison, Rebo favored over palbociclib as compared to palbociclib. Next slide. So Rebo has shown a numerical PFS and OS significant survival benefit over palbociclib in match analysis indirect comparison. Next slide. Next slide. All these including criteria were different. If we took Mona Lisa or Monarch, the patient population was different. If we see into Monarch 3, there has to be a DFI of 12 months if we had to include in the study. And in Mona Lisa 2, there was no such criteria was taken. Next slide. And overall survival is more with if we take the patient population which are hormone sensitive, then the treatment-free interval is more than 1 year. So OS was in Melissa 3 or more, 2. The difference was more if the patient population was hormone sensitive. Next slide. Talking about quality of life with CDK4/6 inhibitor. Next slide. So the quality of life, almost all it was similar, and there is not a deterioration in quality of life in the patient. Next slide. If we look into side effect, the fatigue, neutropenia, they are more with the palbociclib, QT prolongation, and this skin toxicity are more with the ribociclib, and diarrhea, the most common side effect that is more common with the ribociclib. So side effect profile is slightly different in all these CDK4/6 inhibitors. Next slide. So that is the same indirect match analysis comparison. That Rebo is better against other CDK4/6 in result to quality of life. Next slide. So if we talk about the pharmacological the characteristics, yeah, CDK4/6 are definitely different when they come to work. So these are the minimum inhibitory concentration that with they start action. Ribociclib, palbociclib, and abemaciclib. Next slide. And there is a differential activity for all these CDK4/6. CDK4 play more important role in a breast cancer as compared to CDK6. Next slide. And Rebo and Abipa, they are more active against CDK4 as compared to CDK6. Next slide. So this is similar data that they have a differential activity on CDK4/6, all the CDK4/6 inhibitors. Next slide. This is similar that they have a different CDK4/6 inhibitor potential. Ribociclib acts more on CDK4, similar to Abema, and palbociclib acts on CDK6 more than CDK4. Next slide. And it has been shown that Ribo acts more on the tumors to stabilize it, to make it more in a luminal subtype as compared to other CDK4/6. So that tumor is more and more hormone sensitive, and the progression is delayed and overall survival is good. Next slide. So that is the same that Ribo stabilizing the tumor in luminal subtype as compared to palbociclib. And to gain or loss of hormone receptor was more with the palbociclib as compared to ribociclib. Next slide. And if you look into the use of chemotherapy post progression in Reboot versus palbociclib, the use was more in palbociclib, that was 34% as compared to ribociclib, that was 29%. Next slide. And there is a carryover effect in the patients who were ribociclib. The patients who were taking first line ribociclib, their progression after second line was also delayed as compared to if they were taking ribociclib. And which you see if they were more and more hormone sensitive. Next slide. And Paloma 3 has shown that the progression is compared to ribociclib. Next slide. Next slide. Next. If you look at the guidelines, so NCCN has preferred option in the first line metastatic breast cancer setting, hormone positive, HER2 negative. Next slide. So we talk about the ISMO, the magnitude of benefit is higher, and they have also higher as compared to Reboot or palbociclib. Next slide. So in summary, if you look, though we are saying that CDK4/6, and if we look into trials, the benefit was substantial and significant with these monolista trials of ribociclib. And as you know that these all CDK4/6 inhibitors, they are not same. They have differential activity in CDK4 versus 6, and that is the reason that the OS benefit was greatest with the ribociclib, and it is the only CDK4/6 that has shown significant overall survival in first line setting, and it should be preferred as a first line with a repeat partner. Thank you so much.
Thank you, Dr. Gurvinder. So I think these slides are well made in favor of ribociclib as compared to the MA or palbociclib. Though the main point is the overall survival data is best with the ribociclib as compared to the other CDK4/6 inhibitor. So, but maybe that now future is there that if you have progression post one line of CDK4/6, you can reuse a next line, second CDK4/6, which we recently discussed just 2 lectures previously, that abemaciclib, which was given in a patient who initially received approximately 38% patient have received initially ribociclib. On progression, they were given abemaciclib. So I think if you use this drug in a sequence, starting ribociclib and progression, you start on abemaciclib could be one option.
Yeah, that's true. And I think if you look in data also, Reboot has shown a great benefit in OS. Paloma, I don't know about it. The OS was not significant. Ubima is also a good option in first line. The only issue is cost. Ubima is more costly than that Reboot. And if you look into second line, there are a lot of options that are coming. The last line is also coming in third line. And cabosertib, that is also good. So maybe more and more options will be coming in the second or third line.
So that's why if we use very judiciously first line ribociclib, and when the patient had a good outcome with a good overall survival benefit right now about a good data and evidence. So post progression or ribociclib with the endocrine partner as a aromatase inhibitor. So the next line of abemaciclib plus fulvestrant is the next very good option, which we have just seen that the PFS has approximately reached to 8 to 10 months post first line. So this could be one way that how we can sequence this CDK4/6 inhibitors if we have all 3 in our baskets. So that maybe using ribo or palbo initially, and post progression, abemaciclib can be the next drug. So this could be one information I just concluded after listening the post-NARC trial and the trial from insights. So thank you, Dr. Gurvinder. Thank you for giving this lecture on the CDK4/6 inhibitor ribociclib, sharing that data from this. So next session is from Dr. Rajit Rantan. So he's a medical oncologist at Ojas Hospital, Panchkula. So he will be taking a next journey through HER2. This is a talk of town right now. We are discussing a lot about HER2 positive metastatic breast cancer second line, but this is coming right now in low and ultra low tumor, even and HER2 negative tumor, hormone positive. This could be a game changer in next when we don't have the good lines and we don't have the mutation like PIK3CA mutation, P10 mutation, or it might be even the patient who does not respond well or over even hormone resistant, primary hormone resistance. So over to Dr. Rajit Ratan.
Thank you, Dr. Singh, for the wonderful introduction. Can I share my screen if I'm allowed?
Technical team, kindly help Dr. Rajit.
Sure. So, is it visible to everybody, my screen?
Yes, yes, Dr. Rajit.
Right. So, yes, the talk of the town, trastuzumab deruxtecan, and its role in HER2 expressing tumors is something that I will be discussing in coming 10 minutes. So the agenda of today's meet is trastuzumab deruxtecan in the management of first HER2 positive metastatic breast cancer, and then in HER2 low and its clinical implications, and finally summary and conclusions. So first, in the HER2 positive group, trastuzumab deruxtecan, a little bit of introduction for this drug. It's an ADC, an antibody drug conjugate, which has basically three components. Anti-HER2 humanized immunoglobulin IgG1 monoclonal antibody with the same amino acid sequence as for trastuzumab. It is then covalently linked to the main drug, which is the main payload, a topoisomerase 1 inhibitor, and via a tripeptide-based cleavable linker. This trastuzumab deruxtecan comes with three key attributes. There is a payload which has a high potency, a high drug-to-antibody ratio of about 8. The payload has a short half-life as we desire. There's a stable linker payload. It does not get destabilized before entering inside the cell. It thus makes it tumor selective cleavable linker, and it also has a bystander anti-tumor effect, which makes it slightly more potent than its predecessor, trastuzumab emtansine. Coming to the basics of mechanism of action, whenever the trastuzumab deruxtecan binds to the HER2 receptor, it gets internalized, and when inside the cell, the linker gets cleaved and the topoisomerase 1 inhibitor is released. This topoisomerase inhibitor does what it does, and it causes tumor cell death. And once tumor cell death occurs, the cellular membrane becomes permeable, and the payload is then also delivered to the bystander effective cells. And it has shown in various trials a good response to patients who are HER2 positive. A tune of about 60% is considered to be a good response rate, which is seen by this very own drug. The main trial in HER2 positive breast cancer was a Destiny Breast 03 trial. It was an open label multicentric phase 3 trial. And they took HER2 positive patients, HER2 2 plus with FISH positive or HER2 3 positive. They were unresectable metastatic and had to be previously treated with trastuzumab and taxane. They could have had stable brain metastasis with more than 3 weeks between whole brain radiation and study enrollment. Stratification factor in this study was hormone receptor positive status, prior use of pertuzumab, history of any visceral disease. And these patients were randomized in 1:1 fashion between trastuzumab deruxtecan and the TDM1, which was at that point of time the standard of therapy. Primary endpoints were PFS. A key secondary endpoint was overall survival, with overall response rates, duration of response, PFS, safety being other secondary endpoints. And there was also a exploratory subgroup analysis based on disease history, prior setting of lines of chemotherapy, any prior anti-HER2 therapy that was given was also taken into account. The key demographics of the Breast-03 trial was 50% were hormone positive, 15% had baseline metastasis, 70% of them had visceral disease, 61% with prior trastuzumab, and median of 2 lines of therapy was there. And the anti-cancer therapy mostly used was TDM1, and in the post-trial setting as well, there was TDXT arm. Some of them had received TDM1, and in the TDM1 arm later on received TDXT. So if you come to the results of the trial, very impressive results with a median PFS of 28.8 months in these heavily pretreated patients, which was never seen in such settings, compared to the control arm with TDM1, which had only a median PFS of 6.8 months, a hazard ratio of 0.33. It also reflected in the overall survival with a 2-year median OS of 77% in TDXT arm versus 69% in the TDM1 arm, with a hazard ratio of 0.64. So this trial established the supremacy of TDXD. Regarding the adverse effects, the ILD, which we all fear, was about 15.2%. However, there were no grade 4 or grade 5 ILDs. Other important toxicities pertaining to the topoisomerase inhibitor were nausea, vomiting, alopecia, and 16% of grade 3 neutropenia, which we all have to be wary of. There were some key subgroups of interest which were analyzed. There were concerns that with age, the amount of pneumonitis might be higher. And when we stratified these patients with respect to age, an age less than 65 to age more than 65, the responses were consistent in both the age groups, and they were consistently higher than what was seen with other therapies. Destiny Breast 01 showed similar responses, similar PFS advantages in both the subgroups of age. Similarly, Destiny Breast 02 and Destiny Breast 03, they did not show any detriment with increased age or decreased efficacy with increased age. Were the side effects also pretty similar? The answer is yes and no. The most lethal side effect that we know of is the ILD. The grade 3 ILDs were equally distributed between the arms. So if you, so TDXT grade 5 pneumonitis was about 0.9%, and in less than 65, and in more than 65, it was about 0.6%. Coming to the brain metastasis, has shown impressive results even in patients who have brain metastasis, whether they were treated or whether they were untreated or active. In the treated subgroup, the control arm obviously did well because they had received some radiation. However, in spite of controlled brain metastasis, TDXD did show its superiority in terms of a good PFS advantage and a median PFS of about 12.3 months in the TDXD arm versus 8.7 in the comparator arm. In the difference was stark in patients who had an active brain metastasis, with TDXD consistently showing good responses and a good PFS. A PFS of 18.5% in an untreated brain metastasis is actually fantastic. In comparator arm, which had TDM1, fared poorly with only 4 months of PFS. These waterfall plots also tell the similar story. Brain metastasis responding very well in TDXD arm. However, in the comparator arm, which had trastuzumab, capecitabine, lapatinib, or other therapies which actually cross blood-brain barrier, did not show that impressive results with respect to response rates. There were other trials also which showed similar results. The Tuxedo 01 was a small prospective trial which showed a PFS of about 14 months and intracranial response rates of about 73%. Similar retrospective analysis, Rosette BM, also showed impressive brain control in patients receiving TDXD. That was in HER2 positive patients. So it seems that HER2, these drugs also function in HER2 low patients, and thus HER2 becomes an important biomarker, and its interpretation becomes a little wider in our clinic. Since HER2 is basically divided into HER2 absent, 1+, 2+, which is FISH negative, and 2+, which is FISH positive, and HER3, and HER2 positive. By HER2 positive, we mean 2+ FISH positive and 3 positive. Now the scope of patients treated with this therapy has increased. Now we have approximately 43% of addition of patients who can receive this therapy beyond the HER2 settings. As you can see, the incidence of HER2 low is approximately 43% in non-metastatic patients and nearly 53% in metastatic patients. But we obviously have challenges with respect to HER2 analysis. There is no real definition of what is HER2 low. There's lack of awareness of HER2 low. There are problems with biopsy specimens which degrade. There is obviously some heterogeneity in the tumor. Sometimes the HER2 potential of the tumor is not picked up. There is subjective difference between HER2 analysis, and there is sometimes questionable quality of labs which do it. And there are limitations in the design of various HER2 levels. So thus, if we have a patient who comes to you as HER2 negative, and there is merit in identifying, doing a rebiopsy and identifying whether the patient is certainly HER2 absent or there is some potential in giving in the HER2 levels. So why this discussion is because HER2 TDXD has shown good efficacy in HER2 low breast cancers as well. Impressive irrespective of whether they were hormone receptor positive, IHC2 positive, IHC1 positive, overall response rate of about 35% in IHC1 plus, or even prior CDK4 inhibitor use. So this theory was tested in Destiny Breast 04, where HER2 low patients defined as IHC1 plus or IHC2 plus FISH negative, which are metastatic, had prior 1 to 2 lines of chemotherapy in metastatic setting, may have been hormonal positive with endocrine refractory. They were randomized 2:1 into trastuzumab deruxtecan versus therapy of physician choice, which included capecitabine, eribulin, gemcitabine, paclitaxel, nab-paclitaxel. Obviously, the chemotherapies that we tend to give in HER2 negative settings. And the primary endpoint here was also PFS by blinded independent control. And there were key endpoints, PFS, OS, and other secondary endpoints as well. And there were some exploratory analysis also done in the trial post the results were out. So if we see the efficacy in HER2 low patients in hormone positive settings with a hazard ratio of 0.51, TDXD did show an impressive PFS of 10.1 months versus 5.4 months in patients who received therapy of physician choice with a delta of about 4.7 months. PFS in all patients also had similar improvement in median PFS with a hazard ratio of about 0.50. And if we see the updated progression-free survival by the investigators, it also did not show any difference in what was seen earlier. An impressive PFS, and at 24-hour landmark analysis, the TDXD, the PFS of TDXD was about 15.4%, and which was obviously higher than the comparator arm. And similar results were seen in all patients. In the overall survival group as well, in hormone receptor positive patients, in which the OS sometimes is very hard to achieve, it did show an important result in terms of OS benefit and a hazard ratio of 0.64 and a median OS of about 24 months in the TDXD arm versus 17.6 months in the therapy of choice arm. And similarly, the reflect also showed in all comers as well. So how does it fare in the subgroup of hormone receptor negative? As we could identify in the all comers as well, the hormone negative patients also did show an impressive PFS advantage. The advantage was not only limited to PFS, however, reflected in the OS as well, with a median OS of 18.2 months in the testing group versus 8.3 months in the control arm. Side effects were usual. There were some pneumonitis, and any grade pneumonitis was about 12.1%, slightly lesser if I'm allowed an inter-trial comparison. But as you can see, no grade 4 toxicity and very little grade 3 and grade 2 toxicities in terms of pneumonitis. There were, yes, some left ventricular dysfunction issues and some rare issues of cardiac failure. However, this therapy was pretty well tolerated and did not show any new side effects. In terms of response rates, pretty impressive response rates. And as you can see, no difference whether the patient was IHC1 or whether the patient was IHC2. Even in the forest plot as well, the subgroup analysis, there was hardly any difference. Even, I think this is by chance, IHC1 plus had a better sort of response as compared to IHC2 plus. Other subgroup analysis in terms of prior CDK4 use, disease burden, rapidity of progression, HER2 status, prior lines of therapy, age, baseline CNS metastasis, or prior anthracycline treatment consistently showed the advantage of using TDXT over any other therapy that the physicians might have had their favors for. There is merit in doing a rebiopsy because HER2 levels often keep changing even in an ER positive tumor or in a TNBC tumor. A HER2 low can become HER2 zero, a HER2 zero can become HER2 low, a HER2 low actually can become HER2 positive as well. So whenever you are hard pressed about a patient who is triple negative and you don't know what to do, there is merit in doing a rebiopsy because some of may actually turn out to be HER2 low, and thus you may utilize this therapy for such patients. Even in patients who had HER2 testing by central labs versus the historical results, about 78% of the samples designated as HER2 low by prior historical results were confirmed as HER2 low by central testing in the pathway HER2 4B5 analysis. Among the 22% of the discordant samples, 88% were centrally scored as IHC0, and about 12% were scored as IHC2 plus, FISH positive, or IHC even 3 plus. And the median PFS was identical regardless of whether the samples used for HER2 testing were from primary or from the metastasis, and regardless from the tissue collection until the study entry. One important side effect of this therapy is interstitial lung disease. It is important to know the protocol that should be in place once you start your patient on this therapy. The most important of which is monitoring. You have to advise your patients to immediately report any cough, dyspnea, fever, any worsening of respiratory symptoms, promptly investigate any evidence of ILD, evaluate patients with suspected ILD by a radiographic imaging, and consider consultation with a pulmonologist. He should be on board. Confirm it if there is any suspicion with a high resolution CT, have a pulmonologist consultations, you do your blood cultures, CBC, bronchoscopy, and PFT, and then grade these patients according to the severity of it. If the patient has only radiological evidence of pneumonitis, that is he's grade 1, you only delay the dose until full recovery. This is the only indication where even on grade 1, you have to hold your therapy. And
Rajit sir, kindly conclude, please.
I just have a few more slides. So important dose modifications once the patient has to be restarted is from 5.4 is 4.4 milligram per kg is the first dose reduction, and then it is 3.2 milligram per kg. Consider corticosteroid treatment from 0.5 milligram per kg to about 1 milligram per kg depending upon the severity. And do your CT scans at least every 2 weeks for patients who are asymptomatic and 6 to 9 weeks for those who have respiratory symptoms. In summary, HER2 is a dynamic marker which can demonstrate intra and intertumoral heterogeneity and may change from an early stage to late stage. Proportion of HER2 low is higher in HER2 positive breast cancer, in hormone receptor positive breast cancer patients as compared to TNBC. Destiny Breast 04 showed a significant PFS OS benefit in patients who were even HER2 low, who had prior lines of therapy, irrespective of whether they had received CDK4A or any lines of therapy or anthracycline. And TDXT has been approved in about 50 countries, and including India, and is also recommended by various agencies of the world. Thank you.
Thank you, Dr. Rajit. So it was a very good lecture on trastuzumab deruxtecan, which you gave regarding the HER2 positive and even the low HER2 patients. So I just want to ask, do you have any exposure to this drug? First thing. Second,
Yeah.
second means if the patient is HER2 positive or HER2 positive, not HER2 low. So do you do a repeat testing for those patients? And if patient is hormone positive, HER2 low, so whether that those patients are only tested for again hormone positivity or HER2 positivity also. Means what you practice in what you follow in your practice.
For your first question, I have one patient on trastuzumab deruxtecan. She received 2 cycles, was very symptomatic on her first cycle, had failed previous lines of therapy and had brain metastasis. Uh, didn't sort of agree for radiation. I have started her on TDXD on lower doses. I would sort of say she's doing pretty well. For 2 cycles, there were hardly any side effects because probably the dose was less, but she did show some symptomatic improvement. So that's my sort of experience in it. Regarding rebiopsy, I always tend to suggest rebiopsy for my patients, even in those who have had a HER2 challenge by trastuzumab. We sometimes tend to see that the HER2 expression becomes obsolete eventually. Sometimes it doesn't. It's there, sometimes it's not. So we have to be sure before we give such costly therapy to such patients. But as you would agree, there are patients who tend not to go for biopsies. They have their own reservations. So sometimes you have to have a clinical judgment, and based on that, you move ahead.
Okay, so but for the patient who are hormone positive and HER2 low, who are exhausted the hormone therapies, so maybe 2 lines, 3 lines.
Yeah.
So would you like to repeat a biopsy to prove a hormone status and HER2 status again in those patients that they are still low or they're low? Because that doesn't going to change even if it's a low, it's a 0.
Because they haven't received a HER2 anti-HER2 therapy, so you would think that the HER2 status would be intact. Regarding hormone positive, because once you started them on TDXD, you might not want to keep them on any hormonal therapy as well.
So like it's a dictum when we do a rebiopsy of patient of a hormone positive to check whether it's again positive or not. So down the line, like 2 lines, 3 lines, at what time you don't feel of doing a rebiopsy? Like first time you are given a hormone positive, then second time you have to check the biopsy for the hormone status. Again for the third line, do you check? Or for the fourth line, do you check or do you don't check after third or fourth line?
If I have to sort of see what kind of mutations that they have acquired, ESR1 or PIK3 mutations, then I would do it in a fresh biopsy. Otherwise, if I'm planning trastuzumab deruxtecan, it doesn't.
No, my question is like fourth line. If it's suppose fourth line, patient was hormone positive till third line of treatment. So now it's a fourth line. So will you rebiopsy? At the fourth time, patient will be reluctant for the same. So do you feel that rebiopsy will yield something because 3 times you have tested it's hormone positive?
No. If because I think at that point of time, I would be choosing therapies beyond my hormone status, so that would not matter actually.
Okay. Thank you, Dr. Rajit.
Thank you, Dr.
Thank you for your wonderful session. So my next speaker is Dr. Mukesh Bansal. Mukesh, you are there?
Yes, sir. Good evening.
Thank you. Good evening. Good evening. So Mukesh will be taking next topic on sequencing of HER2 therapy, because rightly we have heard again a lot of regarding this trastuzumab deruxtecan in HER2 positive, low HER2 or ultra low or even HER2 negative. So you will be delivering a talk on sequencing of HER2 positive therapies in the CA Over to you, Dr. Mukesh.
Yeah. Can technical team share the slides from the backside? Yeah. Good evening, everyone. Thank you, organizers, for giving me this opportunity. So I will be continuing the HER2 positive.
Abhimanyu, can you share the screen for Dr. Mukesh?
Sharing, sir. 1 second, was.
So managing HER2 positive metastatic breast cancer. Next slide. So if we look 10-12 years back, the treatment paradigm for metastatic HER2 positive breast cancer were used to be taxane plus trastuzumab in the first line. And in the second line, there was no clear-cut answer. It can be trastuzumab plus some other chemotherapy, labcapergine, or endocrine therapy if hormone positive. Efficacy of chemotherapy plus trastuzumab or lapatinib is limited in second line. But since last 1 decade, 6 new HER2-directed therapies has been approved by US FDA. Next slide. So coming to the landmark Cleopatra study, does pertuzumab add to chemo plus trastuzumab? HER2 positive MBC centrally confirmed 1:1 randomization, dosi plus trastuzumab plus placebo, and in the other group trastu pertu plus docetaxel. Next slide. Yeah. So median OS with pertuzumab group was 57.1 months compared to 40.8 months in the other, giving a benefit of around 16 to 17 months with a hazard ratio of 0.69. The curves started to separate in first few months only, and the separation continued. Next slide. So addition of pertuzumab improves overall survival and progression-free survival also. So the landmark progression-free survival at 8 years of around 16% was there. Next slide. Coming to adverse events, the main practical adverse event which we face with adding pertuzumab is diarrhea. Other than that, it can be some more incidence of rash, headache, upper respiratory tract infection, pruritus, but all of these are mild to moderate and manageable. Next slide. So first line therapy, Pertu plus trastuzumab plus taxane became the first line standard of care. While Cleopatra study used docetaxel, Pacli is also reasonable. Next slide. Next. So does pertuzumab add to trastuzumab and aromatase inhibitor in hormone positive HER2 positive MBC also? So postmenopausal patients with HER2 positive and hormone receptor positive MBC LABC are taken. Choice of chemotherapy specified before randomization, and they were randomized one group to Pertu plus trastuzumab plus aromatase inhibitor or chemotherapy, and second only trastuzumab plus aromatase inhibitor or chemotherapy. Next slide. So median PFS was 21.7 months compared to 12.4 months, giving a benefit of around 9 months. Next slide. So the combination of endocrine therapy plus HER2 therapy is active in hormone positive HER2 positive MBC. It can be ideal first line approach for selective patients. We do not currently have optimal tools to identify such patients. Next slide. So what are the ESMO guidelines for first line therapy? If the patient is hormone negative and patient there are no contraindications to any treatment, so dosi or paclitaxel plus combination anti-HER2 trastuzumab plus pertuzumab. If chemotherapy is contraindicated, trastuzumab plus pertuzumab until progression in hormone positive group. Again, if there are no contraindications, same chemo plus trastu plus pertuzumab followed by trastu pertu plus endocrine therapy. If chemotherapy is contraindicated, then trastuzumab plus minus pertuzumab plus endocrine therapy should be used. Next slide. Coming to the second line therapy. Next slide. Yeah. So Amelia study design, HER2 positive LABC or MBC prior taxane and trastuzumab, progression on metastatic treatment or within 6 months of adjuvant treatment. So TDM1 that was standard of care at that time, 3.6 mg per kg 3 weekly, and in the other group, capecitabine plus lapatinib. Capecitabine plus lapatinib was standard of care at that time, and TDM1 was used in the second arm. Next slide. So TDM1 showed a clear benefit of 30.9 months versus 25.1 months, giving a benefit of around 6 months with a hazard ratio of 0.68. At the end of 2 years, around 13% of the patients, 13% of survival benefit was there. Next slide. So what are the main differences between TDM1 and TDXT? So TDM1 is antimicrotubule, while TDXT is topoisomerase 1 inhibitor. Drug to antibody ratio is 3.5 is to 1 in TDM1. It is 8 is to 1 in TDXT. Tumor selective cleavable linker is there in TDXT. Evidence of bystander anti-tumor effect is there in TDXT, which is not there in TDM1. Next slide. So Destiny trial, I think that has been discussed wonderfully by Dr. Rajit. So I will just, so it was TDXT versus TDM1, 5.4 mg per kg 3 weekly versus 3.6 mg per kg 3 weekly in the standard doses. Next slide. So at the end of 2 years, the overall survival 77.41% versus 69.9%, giving a benefit of around 7.5 months, while median overall survival is not yet reached. Next slide. So PFS benefit 26.4 months at the end of 2 years versus 53.7 months, so almost double, with a wonderful hazard ratio of 0.33. Median PFS is 28.8 months in TDM1, while it is not yet reached in TDXT. Next slide. Next. So side effect profile, most common adverse events, more than 20% of patients were routine, like anemia, thrombocytopenia, decreased TLC, nausea, vomiting. Next slide. Yeah, so the major side effect of concern was adjudicated drug-related ILD or pneumonitis. Every grade pneumonitis was more common with TDXT as compared to TDM1. If we see grade 1, 4.3 versus 1.5%, grade 2, 10.1% versus 1.1, grade 3, 0.8 versus 0.4%, while there were no grade 4 or grade 5 adverse events with either of the drugs. With longer treatment exposure and follow-up, the pneumonitis rate increased from 10.5 in the PFS interim analysis to 15.2%. So this is the side effect which needs monitoring. Next slide. So Destiny Breast 3 trial establishes TDXT role as preferred second-line standard of care for most patients with an unprecedented levels of activity and reassuring ILD data. So now what about patients with active CNS mets? Next slide. So CNS disease is frequent in HER2 positive MBC, around 30 to 50% incidence. Next slide. So coming to ESMO guidelines for second line therapy, second line treatment or progression during neoadjuvant or adjuvant treatment, if the patient is patient is not having brain mets or stable brain mets, and TDXT obviously is the standard of care. With active brain mets, if local intervention is not indicated, tucatinib, capecitabine plus trastuzumab or trastuzumab deruxtecan can be used. If local intervention is indicated, then obviously resection or radiation or whole brain RT, depending on the number of mets. Next slide. So coming to tucatinib, which is a potent and selective HER2 inhibitor. HER2 selectivity leads to decreased potential for EGFR-related toxicities compared to dual inhibitors, and it also penetrates CNS very well. Next slide. HER2 CLIMB trial design. HER2 positive MBC, prior treatment with trastuzumab, pertuzumab, TDM1 was allowed. Previously treated stable brain mets, untreated brain mets not needing immediate local therapy, and previously treated progressive brain mets not needing immediate local therapy. One group was given tucatinib plus trastuzumab plus capecitabine. Other was given placebo plus trastuzumab plus capecitabine. Next slide. So updated OS results are 24.7 months versus 19.2 months, giving a benefit of around 5.5 months in the tucatinib group. Next slide. So in patients with active brain mets, 21.4 months versus 11.8 months. So median OS almost doubled in the tucatinib group. Next slide. Next. So most common adverse events, the usual side effects of diarrhea, nausea, fatigue, vomiting was there. Next slide. So does trastuzumab deruxtecan have activity in HER2 positive brain mets? Next. Next slide. So pooled analysis of trastuzumab deruxtecan in patients with HER2 positive MBC with brain mets from Destiny Breast 1, 2, and 3 trial. Next. So this is the exploratory best intracranial response, ORR, and duration of response as per Bicker analysis. As we can see, TDXT was able to achieve even complete responses even in untreated or active brain mets patients, around in 16% of the patients, and in 30% of the patients there were partial responses. Next slide. So TDXT demonstrated a trend towards prolonged CNS PFS over comparator and a noticeably greater advantage for patients with untreated or active brain mets. Next. So approach to therapy for metastatic HER2 positive disease. First line we already know. Second line TDXT is the standard now. In progressive CNS disease, tucatinib with trastuzumab capecitabine can be used. Next. So a new approach, what can be the new approach? Next. That we further divide the brain mets patients with active CNS or CNS dominant with CNS dominant disease, tucatinib, and in active CNS with extracranial dominant disease, trastuzumab deruxtecan. Next slide. So third line and beyond. Next. So ESMO guidelines for third line. No unknown or stable brain mets, tucatinib, capecitabine, trastuzumab, or TDXT or TDM1. If active brain mets are there, local intervention not indicated, same tucatinib, capecitabine, trastuzumab, followed by TDXT. If local intervention is indicated, depending on number of mets, either surgery, radiation, or whole brain RT. Next. Approach to therapy for metastatic HER2 positive disease. I think we have discussed it. Next. Next. So first line taxane plus trastuzumab plus pertuzumab. Second line almost TDXT except in CNS dominant active disease where tucatinib scores. In third line, depending on the second line, it can be TDXT or tucatinib or TDM1. Fourth line can be trastuzumab plus chemotherapy or TDM1. Fifth line, trastuzumab plus chemotherapy or endocrine therapy if hormone positive, or margetuximab plus chemotherapy if low affinity FCR genotype is there. Next. So what are the unanswered questions in HER2 positive MBC? What is the efficacy of TDM1 after TDXT? Is there a role for neratinib or pyrotinib? What is comparative efficacy of TDXT versus tucatinib in patients with active brain mets? Next. Currently, HER2 positive MBC is treated palliatively with sequential therapies continued until disease progression. Given high levels of efficacy of
Sorry, sir,
HER2
for interrupting you. Kindly conclude your talk.
Yeah, yes, in 1 minute. Given high levels of efficacy of HER2 targeted therapy, should we consider treating HER2 positive MBC with curative intent? I think we don't know the answers yet. With this, I will conclude my lecture. Thank you.
Thank you, Dr. Mukesh. So you have summed up all the HER2 anti-HER2 therapies in the sequence which we follow, and of course, post first line after the dual combination of anti-HER2, that is trastuzumab pertuzumab, The next line with us is the TDX, which is right now taking a lead ahead of all the other anti-HER2 therapies. And choosing between TDX or tucatinib, we don't have a direct comparison between those two drugs. Maybe whichever feasible. Of course, the complication with the TDX is different, and with the capecitabine and tucatinib combination is different. But affordability is one issue. And with the recently now we have listened, I think government has cut down the GST on TDX. That could be again a bit, will be a more approachable. So this is I think. Thank you for your all this kind talk. So next session will be for Dr. Nitish. So he will be moderating a session, the patient with the metastatic HER2 positive breast cancer. So Nitish, my colleague in DMC, now shifted to Sohana. So, sir, a lot of shifting was going on last month. Nitish went to Sohana and Gurinder came to Nitish's place. So all this thing going. Over to you, Nitish.
Thank you, sir. So, part of the discussion and everything sort of has happened in the recent updates by Dr. Rajat and then Dr. Mukesh taking over and discussing about the metastatic treatment. So it makes it easy, and also the answers are going to be straightforward. Though we are going to discuss what are the usual things what we face in the clinical practice and some discussion on that. So I hope my slides are visible. And all my panelists are there. Dr. Chitresh sir, Dr. Kanupriya, Dr. Rajiv Saini, I could see.
Nitish.
Dr. Mukesh is there. Hello, sir. Dr. Mukesh is there. Dr. Deepak Singla, sir, I can see.
Yes, I am there.
Dr. Priyanshu, I can see you also. So I hope it has been changed from IV hospital to Livasa hospital already.
I would still prefer to call it an IV.
IV is easy to pronounce it. Until Livasa is a bit difficult, more of tongue twister, I think.
Nobody knows Livasa. IV, some people do know.
So without much delay, so it will be a discussion on HER2 positive metastatic breast cancer. So this case, we will be discussing of a 51-year-old female who is a post-menopausal with no family history of malignancy. Her ECOG performance status of 1. On presentation, complaints of left breast heaviness and lump. On examination, there is an ill-defined lump occupying whole of the upper 2/3 of the left breast. On biopsy, it was ER negative, PR positive, HER2 by IHC 3+. So the PET-CT was suggestive of it is a multicentric left breast disease with left axillary lymph nodes, along with bilateral cervical lymph nodes and bilateral multiple lung nodules, liver lesions, skeletal lesions, right source, left pectoralis major muscle deposit. So with this idea, I think we all know it is a high volume disease, and being HER2 positive, it is going to fit into a aggressive disease. So the clinical diagnosis was made was T3N2N1 stage 4. So I would like to ask Dr. Deepak sir, would you like to get any other investigations at this point of time?
Yes,
Or
I mean,
do you feel these
yes, CMRI can be done. Should be done.
Even if the patient is asymptomatic?
Yes, it should be done.
So, sir, in how many patients of HER2 positive metastatic disease do you consider getting a MRI brain? They come to you upfront in asymptomatic setting.
I mean, again, it depends upon the volume of the disease. Like, I mean, if the low volume, so we always suspect. Brain mets. I mean, majority of the time I get it done. MRI always get it done in the majority of the patients in HER2 positive.
So, yes, you are right, but as such, we don't have a clear-cut guideline stating that. Though we know if a patient is upfront metastatic disease, she has a possible chance of 30% to have a brain metastasis upfront. And if a patient who has a HER2 positive early breast cancer, probably 5% chances in a recent interval she might be having a brain metastasis. So yes, but again, there are no such as such direct guidelines to be discussed on that. If a patient is asymptomatic, shall we do a biopsy, do a MRI of the brain or not? I would like to ask Dr. Rajiv Saini, sir. So what are your thoughts on this, sir?
Nitish, basically, we at most of the center we are doing PET CT with CCT with contrast enhanced CT. So that part is usually take care of if there is any lesion in the brain that will be picked up in that CT phase of that PET scan. So I don't think we have to do MRI unless until we are very highly suspicious of having brain lesion.
Right. So yes, the practices differ. We or some of us consider that if the volume of the disease is high, CE, MRI brain can help us. If the volume of the disease is not high and a patient is asymptomatic, may or may not offer any benefit. If a patient is symptomatic, yes, go ahead and do it. Anyhow, it is going to help us. So in this disease, what you think should be the way forward in the first line treatment? Trastuzumab alone, trastuzumab, pertuzumab with the generic PER2 being available, then chemotherapy, which could be only taxanes or something else. So, Dr. Mukesh, would you like to take this? As you have already discussed it.
Yeah, I think trastuzumab plus pertuzumab if affordability is there, and plus chemotherapy, paclitaxel will be my choice.
Paclitaxel, not docetaxel upfront. I mean, which has been the standard of practice in most of the trials.
I think if there is metastatic setting and paclitaxel, we can replace the docetaxel because it is better tolerable. We can use dosi also, but if the patient has poor performance status, so I tend to replace dosi with paclitaxel.
Right. So there has been some recent ESCO poster updates that in a HER2 positive or even in HER2 negative, if a patient has a high volume or a high risk disease, giving a dose dense therapy may be beneficial. So in case, as Dr. Mukesh said, if finances are not an issue, we are considering only trastuzumab. Will your protocol of chemotherapy is going to change? Are you going to use a dose dense AC followed by taxanes plus trastuzumab? Though it is not a curative intent, just thinking that the patient is going to be symptomatic, the affordability is going to be an issue for pertuzumab.
I will not be using. I will be using taxane plus trastuzumab only.
Right. So usually this regimen has been approved in most of the high risk adjuvant setting cases, not in a metastatic cases, but definitely yes, we can interchange docetaxel with the paclitaxel because we are more familiar with paclitaxel and able to manage the toxicities well, even in elderly patients. Docetaxel can be notorious with neutropenia. We can see even as early as day 5 or day 6. So this was the phase 2 trial and also the trial shown by Dr. Mukesh. So there was an improvement in median progression-free survival and the overall survival with addition of trastuzumab to docetaxel. So then the Cleopatra study where addition of pertuzumab into this has shown an overall survival benefit of 41%. And the reduction in the disease progression to the tune of 34%. So after 3 cycles of this THP regimen, patient had a good partial response with a reduction in SUV and size of the most of the lesions, and was continued on the same regimen. The chemotherapy was stopped and HNP were continued. After 18 months, she had a progression in the brain with CE MRI showing 4 to 5 lesions, but the patient is asymptomatic. Dr. Priyanshu, if this patient would have a systemic relapse also along with a brain metastasis, relapse in the brain, so would you think of doing a repeating a biopsy here?
Depends upon the site of metastasis and ease of biopsy. I mean, and usually there is a 10 to 15% chance of loss of HER2 in the metastatic setting. But during the metastatic treatment, I usually do not go for that. If the patient has relapsed after adjuvant therapy and if there is a disease-free survival is longer, I go for a repeat biopsy. And in HER2, these days for some panels for HER2, they are requiring recent biopsies, especially in CGHS patients. So that is one indication where I do a biopsy.
Okay.
Disease-free
So,
interval is, matching that of Cleopatra, median around 18 months. I don't think so. We are just differing. Yes, if it's a rapidly progressive disease on PTCH, a PTH, it is progressing rapidly, then probably yes.
so that time doing a biopsy and with the comprehensive genome profiling might give us the answer. But yes, as you rightly said, so I just wanted to know, in case you do a repeat biopsy and HER2 comes low, or HER2 comes 2 plus and by FISH it comes negative, do you think that stopping anti-HER2 therapy is going to benefit us?
In this case, otherwise also your option would be an HER2, which is approved for HER2 low also. And the second is, there can be tumor heterogeneity in between the sample and at different sites too. So maybe we can still continue HER2 therapy if there was, especially if there was a response initially. And I don't think so based on a single sample. If the patient has a liver and lung metastasis, bone metastasis, and you're getting one sample from liver or lung, so it can still harbor sites where HER2 loss will be there. So we can continue.
So,
And for HER2, I don't think so that should be a problem.
So there has been a thought that in case it is a disease is HER2 positive, the chances, even after it becomes HER2 negative on the biopsy specimen, there are chances that it may still behave like HER2 positive, and continuing the anti-HER2 therapy is going to benefit. So once a driver is found, we should always be thinking of continuing that anti-driver, or stopping the driver from driving the car and taking it further. So yes, how many sites is the thing. So it becomes difficult for the patient to get multiple biopsies for multiple sites. Yes, we sometimes tend to check this HER2 status again if it would have been more than 24 or more than 18 months anyhow, or if there would have been a gap of more than 6 months, we would tend to do a biopsy. So this he has already answered and we have discussed. So Dr. Mukesh, why do you think that these patients get brain metastasis?
Sorry, what was the
So
question?
why do you think the HER2 positive patients get brain metastasis?
I think HER2 positive is a aggressive disease. So any organ metastasis is more common, and that may be the reason. I don't know the exact reason.
So the specific biology behind is that the receptors, they stimulate the other receptor sites as well. So there is quick HER2 HER3 dimerization, overexpression of HER2 and HER3 along with mutated EGFR, which increases the chances of the cell signaling and tumor progression. So this is the common. It was initially a hypothesis about 2 years back. So this theory has been proven that multiple things are involved, multiple receptors are involved in causing the brain metastasis, and this is a probable cause or the reason behind it. So when we talk about brain metastasis, does it have any correlation with the BRCA1 or 2? Dr. Rajiv, would you like to take it, sir?
So HER2, you are talking about HER2 positive patients?
Yes. HER2 positive with brain metastasis. Is there any correlation with the BRCA1 or BRCA2?
Nitish, I'm not aware of it. I think there is no such correlation, but maybe there is. I am not aware of it.
So what I could recall was that there is a correlation with BRCA2, not with 1. So the BRCA2 with HER2 positive malignancies, though we don't tend to check them in HER2 positive, we don't tend to usually do BRCA1 or 2 germline. There is a correlation that BRCA2 has slightly higher chances of brain metastasis. So I would like to ask any of us among the house, have we ever thought of that adding pertuzumab or even giving TDM1 in the adjuvant setting, does it reduce the chances of bone metastasis in early breast cancer? So if you look at the Catherine study data, there was no significant changes or incidence of reduction in brain metastasis. So this was also seen that there is no such relationship when even we achieve a PCR. So even after achieving the PCR, this was an MSKCC study, it has shown that the brain metastasis number remains the same and they are not correlating with achieving a PCR or not PCR. So in case this patient had 4 to 5 metastases, Dr. Deepak, would you like to go ahead with any therapy as the patient is asymptomatic, or would you like to any local therapy in this case?
Yes, I mean, I know where exactly they are located. I mean, metastasis. What is the size of the metastasis?
So two of them are in the frontal lobe on the right side, and three of them are in the parietal lobe on the right side.
Yes, then definitely I will take my radiation oncology colleague opinion, and definitely I would like to go for some local therapy.
Okay.
Yeah,
even if the patient is asymptomatic. Sorry.
Yes.
Okay. Okay. So won't you be considering thinking about Enhertu at this point of time, sir? Because we know that Enhertu trial had shown if the patient is asymptomatic, even though few sites of metastasis does not change anything, or you are considering it as a oligometastatic disease.
No, I mean when the when the other sites are very well controlled. Okay, I mean below neck, below brain, if everything is controlled, so I won't changing the baseline therapy, and I would like to go for this local therapy. In case the further progression, we can switch to the another molecule, because TDX1 is not a such molecule which can be easily tolerated.
Okay, right. So thinking on the lines that,
and plus there should be some bone directed therapy also. I think in the beginning, I think you have mentioned that there is skeletal mets were also there. I think.
Right. So I think yes, we extrapolate this data from probably lung, where we think of something called oligoprogression. The number of sites are less; they're localized to one or two of the lobes and can be easily dealt with the local therapy and continuing the same therapy. This is what you mean, that we give a local therapy and continuing the same therapy which has been continued, right, sir?
Mm-hmm. Yeah.
Any difference in the opinion from rest of the members?
You can use lab cap also. TDXD per se, I don't know. 1% of my patient would be affording, to be very frank.
Right.
So, and lab cap is a decent drug. I think we have been underusing it now because of newer
Oh,
therapy.
definitely. So
I think Nitish,
Nitish,
this patient is receiving trastuzumab, pertuzumab in
Yes.
maintenance, and
Yes.
after 18 months, this patient progress in brain.
Yes.
So
Yes.
I think the systemic disease is well controlled by trastuzumab and pertuzumab, and we all know that CNS penetration by these two drugs are very less. So I think in this case, if either we should subject patient to local therapy like radiation, or we can add capecitabine to existing regime rather than changing the HER2 regime. That could be one of the options.
Okay, right. So once we think about brain sir is there. Dr. Chitresh, your opinion?
No, so I think that because the systemic progression is not there, so doing a local therapy now and continuing the same systemic therapy would be my choice. SRS would be the best option, and as Dr. Priyanshu mentioned, if SRS or radiation is not available, then LabCap also is a good option.
Definitely, LabCap, I would be happy if it is only brain metastasis and followed by SRS. Maybe I can still consider, because I had a couple of patients who are doing very well almost about 28 months of therapy on LabCap and no progression till now. So LabCap are definitely underused, or I should say they are David versus Goliath. We talk about Enhertu, pertuzumab, but this is a very underutilized drug. So if this patient, as we discussed, has a isolated brain metastasis, then the way forward is local therapy and continuing the same chemo, or in case changing over to LabCap, or anyone for Enhertu at this moment of time.
No, no from my side.
No.
No.
Okay, great. So if this patient had brain metastasis at the baseline, what could be the treatment of choice? The sites are the same: 2 in the frontal, 3 in the parietal on the right side.
No, I didn't get the question. So are you saying
So
that those are symptomatic brain mets?
Asymptomatic.
Asymptomatic brain met.
Yes, at the baseline. So the time we have diagnosed her as a metastatic breast carcinoma, she had, along with the liver, lung, and bone, there were brain metastasis also.
But they were
asymptomatic. Yes.
Okay, so I would still go the systemic therapy way and wait for the the symptoms to appear for the SRS or any local regional
Right.
therapy.
Right. So, Dr. Kanupriya, are you there?
Yes, I'm here.
Yeah. Would you like to take this question?
Yeah.
What
So
would
I
be
would
your
also
opinion?
like to go with the systemic therapy, because the brain mets are asymptomatic right now. So start with chemotherapy along with dual anti-HER2.
But then what do you think about, we have recently discussed that there is a point that the penetration of these drugs into the brain is not going to be that great. So do you think disrupting a blood-brain barrier we should think about some or the other form of therapy which can increase that
So
benefit?
in that case, if the performance status of the patient is good and she can tolerate dual chemotherapy, I would add carboplatin to it, which would have a good brain penetrance also, and that would, I think, take care of the brain mets.
Okay. Dr. Mukesh? And Dr. Rajiv, can you take it, sir?
Yeah. So since we have only 3 or 4 brain mets, if even it's presented baseline, since the systemic burden in this patient was very high, so I'll start THP in this case and wait for CNS symptom to repair. And if the patient had CNS symptom, after some time we can target it with SRS.
Right. So I think everyone is on the same page that if the patient is symptomatic, that time we can add the local therapy, otherwise continue with the systemic therapy, not to capecitabine plus lapatinib regimen in the upfront setting, right? Okay, so this is the usual thing, the chart or the flow chart, what Dr. Mukesh has also discussed, that if the patient has progressed within less than 3 months, 12 months of neoadjuvant therapy, patient can be given the THP regimen for 4 to 8 cycles and then reassess. No CNS metastasis, continue the same therapy. As soon as the patient develops active CNS metastasis, which may or may not be symptomatic with the edema, then tocartinib, capecitabine, and trastuzumab may be a drug of choice or a protocol of choice. If the brain metastases are small and asymptomatic and no significant edema is seen, maybe in the second line we can use Enhertu or TDXT. Then shifting over to, in the third line, tocartinib, trastuzumab plus capecitabine. So if the patient had excess issue in the first line MBC, now with the pertuzumab biosimilar to be added with trastuzumab, if the access allows, I think all of us are going to consider it. Yes. Is it a yes from everyone? Can I hear that yes?
Yes.
So yes, so I think everyone agrees. So pertuzumab definitely gives us an answer, but again, brain metastasis is going to be a challenging thing even in HER2 positive patients. Though pertuzumab, along with trastuzumab, has given us a better response. So that's all from me. Thank you.
No, yeah.
Thank you, Dr. Nitish. So this was regarding the metastatic breast cancer, HER2 positive, and what different line, what options can be used, and depending on the patient's tumor burden status. So we are running late. So next session is by Dr. Priyanshu Chaudhary. So he's a medical oncologist at now called Levasa Hospital. So he will be taking on the olaparib triple negative breast cancer. Over to you, Dr. Priyanshu.
Thank you, sir. I will share my screen. I hope it's visible.
Yes, it's visible and it's in a
So I
presentation.
have a large number of slides, so I'll be taking just 15 minutes. So I'll be kind of rushing through the slides. So my topic today is early breast cancer, TNBC, my takes in this year. So this is agenda. Why TNBC is still a big problem. We know we have neoadjuvant, adjuvant therapy. What is the role of platinum, immunotherapy, and PARP inhibitors? So we all know 10 to 15% of all breast cancer triple negative. In India, probably slightly higher, maybe up to 20%. In America, it is more in Afro-American young women, and it harbors germline BRCA mutation. So we all know that TNBC is actually a bad disease, the worst among the three, I would say. Early TNBC associated with early recurrence and high mortality, especially when we don't have a PATH-CR. So if we see distant metastatic disease has only 11.5% 5-year survival, even in regional and localized disease. The survival is worse compared to hormone receptor positive and HER2 positive disease. So we all know that these days we have to see not just HER2 IHC, but we have to look for HER2 low, HER2. Now we have data for ultra low also coming up. We have to see BRCA1 and 2 and also HRR genes, look out for HRD and loss of heterozygosity, contraindication to chemotherapies. So currently the standard of care, the first NACT data in TNBC came from NSBP B18 and B27 studies. There was improved EFS and improved PFS and OS in patient who had a PATH-CR on NACT. So this was especially true for TNBC and HER2 positive disease. So then we had another dose dense therapies coming up, especially the weekly Paclitaxel had improved DFS and OS compared to 3 weekly dosing in the ECOG 1199 study. Then we had a lot of debate on what is the role of platinum in neoadjuvant setting, especially in the triple negative setting. So there were trials, JAPA 6-2, Brightness, CalGB 40603. So these trials showed that platinum-based NACT significantly improved PATH-CR with a trend towards improved DFS at the cost of higher risk of hematological toxicity. And it did not answer what was, the responses in BRCA-mutated cancers. So then we again came back to India. Dr. Sudeep had this trial in Tata, which used paclitaxel 100 mg per meter square plus carboplatin AUC2 weekly for 8 weeks, followed by AC or EC. Control arm was same as above without carboplatin. So again, a very good trial. Almost 70% patient were less than 50 years of age. 60% had a T4 or N2, N3 disease, that is a LABC. Then after NACT, around 89% had surgeries, and more than 5 centimeter disease was 77%. So if we see here PATH-CR when compared, that is PT0N0 again significantly higher with the addition of carboplatin, 54.5 versus 40.3. If we see PAT-CR only in breast, again higher, 61.9 versus 43.8. Only in nodes, 77% versus 71.6. So if we see here, the toxicity definitely on the higher side, but it was manageable. So EFS and OS again significantly prolonged with the addition of carboplatin to the standard of care, that is taxane plus EC or AC. So benefit was mainly restricted to young population less than 50 years of age with respect to EFS, OS and PATS here. So there is again meta-analysis also coming, which is from AIMS, which also showed that carboplatin is beneficial with respect to PAT-CR and survivals. Then the newer kids on the block, we have a plethora of drugs coming, immunotherapies. First one was the Keynote 522 trial, 2019 trial, a very, I would say, practice-changing trial. Then we had IM Passion 031, Neotrip, Jepar, Nubo, iSpy 2. So we'll be discussing them one by one. So Keynote 522, we all know the protocol. We have read it again and again. Paclica plus EC or AC plus Pembro versus Paclica plus EC or AC versus placebo. New adjuvant phase followed by surgery and then adjuvant up to 9 cycles of pembrolizumab. The primary endpoint was the PAT-CR and DFS and so the improvement in PAT-CR, if we see again significantly higher, almost 13.6% improvement in PAT-CR rate, 64.8 versus 51.2. Both PD-L1 positive and negative benefited, although the proportion of PD-L1 negative was less than 20% in this trial. Again, 14.2% benefit in PD-L1 positive and 18.3% absolute benefit with respect to PAT-CR in patients with PD-L1 negative disease. So the approval is irrespective of PD-L1, and the improvement in EFS, again, if we see here at the interim analysis 4 and then at the 6, again, both of these are showing significant improvement in event-free survival. If we look at the latest analysis, 81.3% EFS at 5 years versus 72.3%. That is around 9% improvement in EFS with addition of Pembro to chemotherapy backbone. So almost all of the subgroups achieved EFS benefit, which we can see here also. Then EFS according to stage, if we see stage 2 and stage 3, again, both are getting benefit, especially if you see the patients who have achieved PAT-CR in stage 2, they have a 5-year EFS of around 94% and 85% in stage 3 patients who have achieved PAT-CR. So achieving PAT-CR again is very important. If we see even in patients who do not achieve PAT-CR, the Pembro arm is doing better compared to the standard chemotherapy. The toxicity was on expected lines, infusion reactions, hypothyroidism, skin toxicity, hypothyroidism, adrenal insufficiency, pneumonitis, thyroiditis, hypophysitis, colitis, and hepatitis, which we all see with standard immunotherapy. Then this was IM Passion 031, addition of atezolizumab to neoadjuvant chemotherapy in stage 2 and 3 TNBC, atezo plus nab-pacli, followed by atezo plus AC, followed by surgery and 11 doses of atezo, versus placebo plus nab-pacli, placebo plus AC, followed by observation. So if we see again in the intention to treat population, all randomized, 17% benefit with respect to PAT-CR. Again, both PD-L1 positive and negative are benefiting. But when it comes to with respect to EFS, the benefit was numerically better, but not statistically significant in this trial. So although PAT-CR improved, but the EFS did not improve significantly. DFS and OS again, not very different, numerically better, favoring atezo, but statistically again not significant. So then coming to durvalumab, Durva plus Napacli, then Durva plus EC, followed by surgery versus Napacli plus placebo and EC plus placebo followed by surgery. Primary endpoint again PATH-CR, secondary IDFS and OS. So at interim analysis 4, there was a statistically significant and clinically meaningful EFS benefit. And IDFS benefit was also there, 85.6 versus 77.2%. Again, significant with respect to IDFS. Then coming to adjuvant atezo, this was the Alexandra or IM Passion 03 trial again. Atezo plus chemotherapy versus chemotherapy only arm, similar to what we have seen in other. Then the primary endpoint was IDFS, which was not met, and futility declared because the observed hazard ratio of 1.12 crossed the non-binding futility boundary of more than one hazard ratio at the interim analysis. This was again a failed trial. Now coming to a lot of our patients are actually not able to afford IO drugs. So what is the role of capecitabine? We have the landmark CREATE-X trial, early HER2 negative breast cancer patient, residual disease after neoadjuvant chemotherapy, capecitabine versus follow-up, both DFS as well as OS benefit was seen in triple negative cancers. So if we see here again, capecitabine versus control 0.58 is the hazard ratio for DFS, and for OS it is 0.52. This has been the standard of care till now in patients who have residual disease. So now coming to the PARP inhibitors, so we have now olaparib for high-risk BRCA mutated triple negative breast cancer. So the main thing to remember in this trial is the criteria which they took for high risk. In the neoadjuvant setting, triple negative patients who had non-PATH-CR, and in the adjuvant group, triple negative with PT2 or PN1 disease. So they were again randomized to olaparib versus placebo, and IDFS was the primary endpoint. OS was secondary. So post neoadjuvant olaparib for high-risk BRCA mutated TNBC, again IDFS was better at 3 years, 85.9 versus 77.1. So 8.8 percentage points of difference in IDFS, hazard ratio 0.58, statistically significant. OS again 3.7% better, 92 versus 88.3 in high risk BRCA mutated triple negative post neoadjuvant therapy at the end of 3 years. So again, slightly confusing forest plot here, but I think we will skip this. Then we have what are the adverse events. We all know they were online with other disease status where we have used olaparib, hematological toxicity and GI toxicity mainly, along with fatigue. So now coming to the future directions. So immunotherapy innovations, we anticipate enhanced efficacy and reduced side effects of immunotherapy for triple negative breast cancer and reduce cost too, I would say. Expect personalized treatment approaches utilizing genetic insights to target specific mutation in triple negative breast cancer. Then we have to look out for novel treatments like antibody drug conjugates and combination therapy to revolutionize triple negative breast cancer management. So here we know that neoadjuvant usually is the standard of care for any disease which is T2 onwards, I would say, or more than 2 centimeter, I would say T1C onwards or node positive. The main crux is we would like to achieve a pathological CR, and the benefit of neoadjuvant therapy is that we can upgrade therapy if we don't achieve PATH-CR with respect, if we are not using IO at baseline. So again, we have the option of immunotherapy addition of pembro, or we can use, if not affording, we can use a combination of taxane with platinum plus cyclophosphamide and erythromycin or apirubicin. And again, for non-BRCA mutated patients with no PAT-CR, you can use capecitabine. For patients who have BRCA mutated, you can use zolaparib. And the question would, again, there would be some confusion regarding patients who have received neoadjuvant pembrolizumab and who have not achieved a PAT-CR, what to do. So you can use sequential pembro followed by olaparib. The question actually has no good answers. So thank you, and over to the organizers now.
Thank you, Priyanshu. So I was just going to ask you that if a patient is a triple negative breast cancer and you're planning a sort of pembrolizumab along with the chemotherapy, so do you do this BRCA testing at the upfront, or you do when the patient is on treatment or post surgery? Do you have any timeline of doing the BRCA testing in patient with triple negative breast cancer?
Sir, I usually do at the baseline itself, depending upon because sometimes for neoadjuvant therapy when we are giving, and we can counsel them for bilateral breast surgeries and oophorectomy also. So I do it at baseline.
So one thing is like that you are planning about prophylactic mastectomy. One thing, because then you have to omit the choice of BCS in those patients, those young patients. One other option why I'm asking, suppose you are starting with the chemotherapy and pembrolizumab, because there would no need of testing the PDL scoring in the patient with the neoadjuvant setting of the CA breast. Suppose after third or fourth cycle patient get a BRCA testing. So would you like, as you was saying that there is still no answer, means what would you do if a patient does not achieve a PAT-CR? So would you give a olaparib in that setting, despite giving a pembrolizumab?
Sir, it all depends upon the PAT-CR. Non-PAT-CR, again, 9 cycles, I would still like to complete pembro and then probably switch to olaparib.
So what I was going to ask, because I will not be reluctant to use a olaparib because a patient who has not achieved a PAT-CR, so he or she will be more at a risk of relapse or recurrence. So I'll be giving the best to the best in the first line setting rather than giving this olaparib when the patient has a recurrence or become a metastatic. That's one thing I think. So initially we just discussed the role of avelumab in the patients as this I have not read through any trial because there is no such trial available. This was just from the ASCO. But avelumab also has not given any benefit in the DFS in the patient with the triple negative breast cancer. And overall survival benefit was just a very marginal. So at this point of time, either if you have not used pembro in the neoadjuvant setting, CreateX trial is the best answer to that question. PAT-CR, if not achieved in the setting of the pembrolizumab, I will definitely combine a olaparib with a BRCA positive in the adjuvant setting. And given dual that if I do both this along with me, combination I don't have an answer because the data is still not there.
Combinations, it's very toxic also, I mean, capecitabine plus olaparib, so would be too toxic, GI toxicity and myelosuppression. And with pembro, again, I don't know what toxicity we can expect.
Lot of drugs, lot of that durvalumab and this this atezolizumab, they came as a new adjuvant also. Though there is a data of atezolizumab and nab-paclitaxel in the metastatic setting, which does not show any benefit and it was taken back. So I don't know why one immunotherapy is acting in and the other two are not acting in the same subset of the patient when we are not taking into consideration the PD-L1 testing. So there are a lot of questions which are unanswered because the data is there which supports the pembrolizumab and not the durva and the atezolizumab.
Definitely, sir.
Thank you, Dr. Pranshu. Thank you for this wonderful talk and discussion with you. So the last session of this topic is from Dr. Jitendra Arora. He's a medical oncologist at Patel Hospital, and he will be delivering a lecture on the innovator biologics in the oncology and role of dual HER2, because we have just talked of this biosimilars which are available with the Indian brands. So still this innovators hold good, or they are still above the edge as compared to the biosimilars. So over to you, Dr. Jitendra.
Good evening, sir.
Good evening.
So can anybody, how can I share my slide? So my slides are visible, sir?
No, still not. So you can ask the tech team. So can you assist Dr. Jitendra, technical support team?
Please help me.
Abhimanyu?
So kindly press to the share.
In the share.
Yes, sir.
Where it is? Okay.
You will find in the
screen.
down.
Okay. Now it is visible.
No, sir.
How to make a share?
Presentation in background.
Now it is visible.
No, sir. Can you there see a share button in green color icon?
Yes, yes.
Yes, sir. Just click on the
Share. Okay, then.
एक मिनी विंडो पॉपअप हुआ होगा सर आपके स्क्रीन पे।
हाँ जी, हाँ जी।
यस सर, तो उस पर आपको आपका प्रेजेंटेशन दिखाई दे रहा होगा अभी।
आया?
यस, राइट नाउ।
Okay, thank you.
Okay, make it a full screen, sir, in slideshow mode.
Just hold on. Now it's okay.
No, sir.
Sundar, you can put on slides that presentation mode. At the right hand side, extreme down, you can see there is one cursor. Just we can move ahead there. There is you can press on that button. कर्सर ਦੇ ਨਾਲ ਹੀ ਇੱਕ ਬਟਨ ਹੈਗਾ ਜਿਹੜਾ
सर अप्रूव कर दीजिए, मैंने आपको रिक्वेस्ट भेजी है।
I'm not able to get it.
Now it's okay.
Just click on slide, sir, and now change.
How can I see my slides?
Hello, sir. Hello.
Dr. Jitendra, you can ask tech support. They are helping you out for. So
yes,
he's not.
They are using the cursor,
Okay.
but
No,
I'm
sir,
not able to see my
नहीं,
slide.
हाँ सर, मैंने आपको रिमोट कंट्रोल वापस दे दिया, आप कंट्रोल कर सकते हो। जस्ट डबल क्लिक कीजिए स्लाइड पे और चेंज करने का ट्राई कीजिए।
Okay. अभी नजर आ रहा है slides?
Yes.
Please
It's
continue.
moving.
So today's topic is sponsored by the Roche company, and the slides has been shared with the company, and I'm going to present out the biological molecules about that. So this is the first cartoon which shows what is the difference between the biological and the small molecules. As you can see the pictures of the salicylic acid, aspirin, it is 20 pounds, whereas the car is 3,000 pound and airplane. So the antibodies are the big molecules as compared to the small biological molecules, and the small chemical molecules are quite small in the size. So this is the complexity of the biological molecules. They are heterogeneous in nature as compared to the conventional drugs. So what is the difference between the biological and the biosimilar? So these definitions has been picked up from the DMC, FD and the IDSA sites. They give the reference biological use as a comparator for comparative studies, and so this definition I will not go through. This can be. So what is the how the biological molecules are prepared in the lab? So the innovator take the host of genetic information into host cell and the production of the protein, and after that it has been fermentation, growing the cell, increasing by the large bioreactor, and there is a purification process which includes centrifugation, chromatography, and filtration, and the last is the fill label packed. So, but biosimilar have an identical amino acid sequence, and the process of the original molecule is quite hefty. So next, what is how the innovator was biosimilar define the process? What is there is a difference in the process? So the amino acid sequence, as you can see here, the DNA molecules are both there. Vector is then cell line fermentation, purification, and product. Whereas in the biosimilar, they choose the vector to cell line fermentation. Most of the procedures are same, but the amino acid sequence and the vectors all are have to be different. So probably a different vector may be there, a different recombinant production cell line can be there between the innovator and the biosimilar. So different production process is there. So what are the regulatory and the development requirement for biosimilars? As you can see there, the opposite two pyramids are there. The originator, the blue color shades in the clinical study is quite large in the originator molecules, whereas in the biosimilar it is quite small. The safety, efficacy, and immunity are quite different between the blue shade region. Whereas in the clinical pharmacology, it is also huge in the innovator arm. Clinical pharmacology, yellow shades is there in quite large. Vivo studies are similar, and the analytical studies in the biosimilar is quite small, whereas in the biosimilar it is quite large. So the safety, purity, and potency is one of the more appropriate condition of use, which help in the licensing this process. So the regulatory package needed, original versus biological, both has to be needed. Now, what is the why sometime biosimilar has been withdrawn from the marketing? As one of the example where in Thailand the erythropoietin molecule was made, and they caused the pure red cell aplasia. They said that if the biopharmaceutical may use increase the immunogenicity and lead to production of the autoantibodies. These autoantibodies cause the pure red cell aplasia in the patient. So this has been withdrawn from the market as they are not identical to the innovator product and cause the red cell aplasia. So what are the point to be considered between this? Biosimilar may be similar, but the innovator are the more important things. Extrapolation of data may not be appropriate, especially in the curative setting. So the data has to be extrapolated, should not be there. Transparency and the clinical evidence is the vital for informed choice and consent. Maintaining batch to batch equivalence is critical for the best patient outcome. So these are the important point where we have to consider difference between the biosimilar and the innovator product. So come to the combination arm. This is the Roche product Phesgo, which is the first fixed dose combination of the HER2 breast cancer patient. So IV infusion was of Prezeta Herceptin is well established, but can present challenge to the patient. How? It is a long infusion, observation time is there, so the nurses and the doctors has to be busy with the IV infusion. There is a challenging and resource utilization because the preparation of the time is long and require high resource utilization, and patient is also needing the venous access for giving the IV pertuzumab and trastuzumab, and sometimes there is a challenge in the IVSS. So Phesgo is the first formulation where there are two monocular antibodies, pertuzumab and trastuzumab, has been combined in the one shot in subcutaneous form and contain. So they have having a what type of formula they have used? They have used the human hyaluronidase, which allows the SC administration in higher drug volume, and it is ready to fix use formulation. No hurdle is there, and it is eco-friendly as well as the patient-friendly. So what is the basic science behind the Phesgo molecules? So as I have told in the previous slide that after SC administration, the skin reformed within 1-2 days and the rapid clearance of the hyaluronidase molecules is there. So in the cartoon they show that the SC layer contains a matrix of the hyaluronidase fiber and the collagen fiber, which limit the subcutaneous volume to less than 1 ml. And the addition of this hyaluronidase to Phesgo temporarily and locally degrade the hyaluronidase at the injection site, and no change in the structure or the macromolecular collagen elastin. And the degradation of hyaluronidase result in the temporary increase in the local acid dispersion area, enabling large volume fluid to be administered. So this is the mechanism behind the combination of this SC molecule. So coming out the what are the trial and where they have been proven or equivalent to the IV solution. This is a Federica trial, and it is a registration trial for subcutaneous administration of trastuzumab pertuzumab, and that trial was designed patients with a newly diagnosis early stage breast HER2 positive breast cancer who are the candidate for the pre-operative therapy with chemotherapy, and the trastuzumab pertuzumab were randomized to standard chemotherapy plus IV trastuzumab pertuzumab versus the subcutaneous formulation. About 250 patients were enrolled in both the arms, and the primary endpoint was the level of the pertuzumab right before the 8th cycle of chemotherapy at trastuzumab pertuzumab, and the secondary endpoint was the through level of trastuzumab secondary level was through level of trastuzumab right before the cycle 8, comparing the subcutaneous and the IV formulation to make sure that over time the steady level of the both the antibodies, and there were no difference between the subcutaneous as well the IV. The another secondary endpoint was the pathological CR on the two arms of the trial. The primary and the secondary endpoint were all favorable, and there was really no statistically significant difference in both the arms. So the pharmacokinetics are the same between the IV and the subcutaneous, and the pathological response were just tiny bit shy, little around 60%, and they were actually same on the both arms. So 60% are a very strong, reassuring, and really excellent anti-tumor activity, getting 60% path CR. So data as per the pharmacokinetic wise, steady state level and the efficacy safety really identical in both the IV as well the subcutaneous arm. So this all I will explain what are the pathological intention to treat analysis, and the adverse effect moreover same in the both the IV as well as the subcutaneous, and the discontinuation rate were less in the subcutaneous arm as compared to the IV. Next is the Francicia C study was a well done trial for the early stage HER2 positive breast cancer, where these patient had received pre-operative chemotherapy, trastuzumab and pertuzumab, then they have their surgery. And if the patient has pathological CR, they were then candidate to finish up their year of trastuzumab and pertuzumab with endocrine therapy if they are hormone receptor positive. And in the Francia study and the adjuvant setting, post-operative patients were randomized to 3 cycles of IV trastuzumab pertuzumab versus 3 cycles of subcutaneous molecule, followed by 3 more cycles after that of the opposite formulation. So if they received the IV for the first 3 cycles, they received the subcutaneous for the second 3 cycles, and vice versa. And the patients were asked which they preferred, whether the IV or the subcutaneous. Furthermore, they were given the option of choosing the regimen. After the finishing of their year of pertuzumab, and overwhelming patient were the favor of the subcutaneous arm rather than the IV arm. So in this trial, they have assessed the patient choice also, as well as they have exchanged the IV as well as the subcutaneous arm in the post-operative setting. So they have asked how much are the satisfied and dissatisfied with the SC or the IV infusion, and I have already explained that the 85%, whereas the 79% in the IV, and the most patient had more than enough time to talk their SCV during treatment. So majority of the patients switching from IV to SCV would have saved time and resources. So 88% of the SCV have quickest form of start of preparation to completion of administration, and the 87% of the SCV felt that the happy patient that the FDCC required less resource usage for preparation and the administration, and 77% agreed or strongly agreed that ready to use resulted in the less drug wastage. So the message that the convenient alternative to intravenous dual blocker of the HER2 has the same efficacy in the form of IV as well as the subcutaneous. So the message that this crux is that the innovator molecules can be the same, but they are not equivalent in the efficacy. And second, the dual antibodies, molecular antibodies in subcutaneous form as the innovator arm is quite efficacious as compared to the IV formulation. Thank you for this presentation.
Thank you, Dr. Jitendra. So I would like to add that definitely Francesca study showed that the patient's preference for the subcutaneous formulation, and Federica showed that patient who received this drug, they already did pretty fairly same what they were receiving in the IV settings, the trough levels. The other thing is only with the in our setting, that is a resource constraint setting, where which we have sometimes complications with the finances we may not be able to utilize. So that there we have to think about of the biosimilars. But the bottom line is that the biochemical trial should be very, very validated with the good data and reproducibility as result as what the innovators are having.
Yes, sir. Yes, agree, sir.
But definitely a patient with the subcutaneous formulation, it is very easy to give and no need to wait much in the our daycare schedules.
Yes, sir.
And patient is more comfortable than giving the IV pricks. And sometimes you are not able to find a vein. That's another complication.
Yes, sir.
So this is one of the easier one. Thank you so much. Thank you,
Thank
Dr.
you, sir.
Jitendra.
Thank you, sir.
So I think we have done for today's session, and it was a good starting from the hormone settings, moving on to the HER2 positive metastatic settings, then followed by a PARP in the CA breast, and finally concluding with the Dr. Jitendra's talk. So Abhimanyu, I think our session completes today, and all have completed their job with the.
Yes, sir.
Thank you.
We can meet tomorrow at the same
Yes.
time at 7 p.m., sir.
Thank you so much. Thank you. So thank you so much.
Thank you, sir.
Good night.
Good night. Technical support, kindly close the meeting.